Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. Robert Gramling, Holly and Bob Miller Chair of Palliative Medicine at the University of Vermont Medical Center. Welcome, Dr. Gramling.
Thanks very much, Matt. Please call me Bob.
Well, Bob, before we kind of get into the main part of our conversation, I always like to let my guests have the opportunity to give a little bit more of an introduction in terms of who they are and what they do. So the floor is yours.
Oh, well, thank you. So my name is Bob Gramling. I'm a palliative care physician at the University of Vermont. I'm also an epidemiologist and researcher. I'm a husband, father, son, brother, and many other identities. Thank you for the opportunity to be here, Matt.
So would you be able to kind of describe for people what palliative care and palliative medicine actually are? Because I suspect that, a lot of people might not actually fully appreciate what that field is.
Sure, absolutely. There's a few different definitions, Matt, that you might bump into out there, and none are perfect, but I'll use one that's adopted by the National Consensus Project and that Medicare has used. Is palliative medicine is a specialty field of medical care that is focused on anticipating, preventing, and treating suffering among people who are seriously ill. So I find that to be, in some ways, the most concise definition that kind of opens up conversation about what that might mean, in fact.
So what first interested in you in going into the palliative care field?
I think in medical school, I was interested, and I still remain interested in the ideas of the country physician, the generalist, the person who's part of people's lives in that relationship. And palliative medicine didn't exist as a formal specialty when I was in medical school. It was only until 2008. And what I found I gravitated to as a physician are those moments of relationship that you cultivate, particularly around times that are, life events, whether birth or death, or others that, sometimes need the help of medicine, sometimes they don't. And those things really drove me. And so when palliative medicine became an option to specialize, it was something that I was really pulled to.
So can you describe kind of what the relationship is like between a physician or other clinician and the patient as you're engaging in palliative care?
Sure. So most of palliative care historically has, we've kind of grown up, so to speak, as a hospitalist consult service, meaning that people are admitted to the hospital for acute care of a serious illness, and palliative medicine physicians, nurse practitioners, PAs, nurses, social workers, chaplains, psychologists, all populate a specialist team, and we can be consulted to help with that person's care in the hospital. Sometimes we also take over that person's care in the hospital, but most of the times we're a person who's part of the team but may not be the primary focus. So when we meet somebody, they're oftentimes already in the hospital, already have met other teams, and in some ways we may be another kind of player in the mix is where that relationship starts.
So, and then from that kind of starting point, how does the relationship evolve?
Well, I think that one of the things that's, I think, fascinating about the role of palliative medicine, at least in this, and I don't want to portray that palliative medicine only happens in the acute care hospital setting. We also are emerging outpatient and community and home-based services that have a similar focus to what I'm going to describe in inpatient, but maybe not as much in the crisis moment that the hospital can be. But I think that what's unique, or what's an opportunity, is that just like you asked at the beginning, some people have no idea what palliative medicine is. They see it on my coat or on my badge. Some people have a perception of what it is, and sometimes that's accurate, or at least aligned with how I might define it, and sometimes it's not. So I think it's an opportunity for introductions of people understanding, why am I showing up there? Who am I? What is my role? What might their role be? How are we going to construct this new, in some ways, emerging social contract about what it means to be engaging in a new type of relationship? And it may feel and look a little bit different than how other people have experienced relationships with their clinicians, particularly in the hospital. So I think I see it as a great opportunity for that initial getting to know one another part of a conversation.
And what are kind of some factors or approaches that help produce a a more positive or a more beneficial relationship?
I think that it's one of the things that fascinates me, both as a researcher and as a clinician, is how do you make space to contemplate? I mean, I think if we're going to address suffering, I think Eric Cassell did a wonderful job in his 82 New England Journal article on describing it as that which threatens the intact of the person. And as a physician, as a clinician, I guess our three general options for how I handle that. One is, well, maybe if I can remove the things that are threatening, then I'll do that, whether it's a form of pain or nausea or other symptom. If I'm unable to remove those threats, or at least they're hard to remove, I also can help shore up who that person is, help them feel known, help their identity feel solid, even amid these threats, as best as I humanly can. And neither of those things can happen well if I don't understand how that person defines themselves. What does it mean for them to be them? And how does the disease and the treatments that are options for them, how does that navigate that identity that may produce senses of suffering or not? And so in order to get there, so to speak, sometimes you get there really quick. Sometimes it takes a while of conversation or multiple conversations for people to grapple with that together. And I guess sometimes we never get there on some levels. But I find more often than not that given the opportunity, people are quite willing to tell you what matters to them, who they are, and what's scary, what's not, what's confusing, what's not, and what types of things we can do that would dignify and honor them better than we're doing.
And you're kind of picking up on what you just said, that a lot of people are interested in and want to have these conversations. Is that, I think that's probably something inherent that, each person wants to be heard, especially in a moment of pain or crisis. And it seems like, kind of as you're describing it, that this is a newer opportunity to have this type of engagement and arguably a greater recognition for the power that it can have in terms of helping individuals.
It might be. I think that at least in modern healthcare, it may be an emerging newer opportunity, at least as some patients and families might experience it. I think historically, particularly physicians, at least I'm more familiar with physician history in the early 1900s, late 1800s, is we used to be really good at being present and helping people understand what's happening and what might be happening down the road. And over the last 80 years or so, we stopped knowing how to do that really well. We got really good at diagnosing and treating, and that's fantastic. We've just not done as good a job as prognosticating, bearing witness to things we cannot change. Those are skills that have not necessarily been cultivated or rewarded in modern healthcare. So in some ways, we're inhabiting a space that did exist in the past, but just kind of got forgotten.
Actually, that's very interesting. It feels like that a lot of conversations end up having it, especially like as we're kind of thinking about value-based care transitions, is things used to be this way. If you look back in time, there was a much better interpersonal connection between the physician and a patient, or a physician and their community, and that almost got lost unintentionally over time. And now we're trying, or the system, I should say, is trying to reassert that, so you have this a better balance between the personal side of things and the diagnostic side.
Certainly, and one of the things that might be different is, because we've been so successful at helping people live longer and for the most part helping people live better, there are just lots of options on the table. So my physician counterpart from a long time ago, she might not have had to help people navigate 10 choices in front of them. There might not have been any. But where we are now is it's a complicated, confusing time, and it's terrifying for people to be able to have to contemplate their own mortality or potential of living longer. But either way, trying to navigate the trade-offs of what types of treatments they're facing and how that might influence their well-being. Those are just conversations that have become more complex as we've become better at helping cure or slow diseases.
And recognizing that complexity, have you been able to kind of tease out, or do you have a sense of some approaches that help to drive a productive conversation? I
think a lot of permission asking, providing space, letting silence be. And I think we're really good threat assessors as human beings. We're really good at assessing, is this a threatening environment? Is this person safe? Am I feel comfortable or not? And if I'm doing my job right, within a short period of time, I think people should hopefully begin to feel a lower level of threat from a conversation, and knowing that I'll leave and I won't push in ways that they don't want or are ready for me to push on. And my agenda is to hear them. I have no other.
So you led that off by, I believe, saying kind of asking permission from people. What does that actually entail?
Well, I think when we're starting to get to know one another or starting to figure out how I might be helpful, if at all, or to explore how much do people wish to take part in their decision making, how much information would they find useful, what types of information, how do they like it delivered, have what I talked about, is it enough? I'm oftentimes in a conversation taking many stops to reflect and say, is what I told you, is that enough detail for what's on your mind? Or would you like me to explain that a little bit more? Or, would you like me to be talking a little bit about what I expect is ahead for this disease? Or is that information that you find very useful right now? And if people don't feel it useful, or if they say no to a question, I honor that. And so I think sooner or later people get a sense that, okay, I will help maybe try to provide some potential options and a roadmap for a conversation that might help me offer guidance if it's wanted. But ultimately, that person is going to be showing me the roadmap about how they want me to get to know who they are. And I think the permission asking is an important piece of that.
It feels like a lot of what you're describing is and I think actually you already said this earlier, is to really be present in the moment. And it's a real process of active listening. So it's not just trying to speak to get through the points, but as you said, trying to really feel out, and not just feel out, but directly ask, what information does the individual want, or what avenues do you need to pursue more, or maybe pull back on?
Yeah, absolutely. Cultivating presence and bearing witness to suffering and being there. I mean, we know when people are not really with us in a conversation, when their head is somewhere else, whether it's tangibly evident if they're on their phone, or you can just tell that they're wondering about something else. So cultivating the ability to let other things go and to be fully present for that other person it's an important attribute of a person who does what I do, or probably anybody who cares for someone who's seriously ill. And it's something that you need to cultivate that. You need to treat it as any other type of expertise that you need to develop and maintain and reward.
And for those of you just joining, I'm talking with Dr. Robert Gramling from the University of Vermont Medical Center, and we've been talking about palliative care. And Dr. Gramling, you were just talking about really being present in the moment, and you can see when someone is engaged in a conversation. I very much get the sense from how our conversation's been going that you've been focused on kind of cultivating these skills for a good amount of your career. As you see people who want to enter into this area of palliative care, or even maybe to develop a similar skill set in physicians who are in other specialties, but it will probably clearly benefit how they are interacting with patients. Kind of what underlying skills do you seek to enhance or to train, and kind of what are the strategies for actually teaching that to people?
So there are really two, maybe three answers to that. One is that one thing we have to stop doing is I mean, this isn't the right image. It's, I was going to say beating it out of people when you come to medical school, but what I really probably should say is sometimes we acculturate people to medicine during medical education that begins to erode some of the things that they came to medical school doing well, like being present or communicating in ways that were human and dignified, and just became more technical through the process. So one is to make sure we are already working with the skill sets people come to medical school with when it comes to communication. And I see that changing a lot in medical education, is really valuing what it means to communicate well, what it means to listen, what it means to explain. I think that is a modern feature of medical schools that is really improving. And the second is to help develop some of the skill sets once you do have some clinical knowledge about how do you engage in that with people. And we're conducting a statewide communication coaching intervention that we call Talk Vermont, led by a colleague of mine, Steve Burns, and Casey Boyle here, to help people practice some of those moments and conversations that may be challenging for people, whether it's responding to terror, whether it's responding to sadness, whether it's recognizing emotion and how do you leave space for that, whether it's encapsulating information into nuggets that are digestible, whether it's pausing in a conversation and letting someone use that space how they wish. Those are some of the things that we practice as fundamental skills. We do it in a relatively playful sort of way with excellent standardized patient actors, and let people practice some of these things that we think of as the curveballs that might come from conversations that worry modern physicians, such as, am I going to die, or something like that, and let people practice them. And we found that this type of approach, cultivated by Vital Talk, which is a national leader in education, communication education, is really improving the satisfaction of a lot of our colleagues' careers. They're feeling more comfortable engaging with people and feeling like some of these really basic skills that they've had a chance to cultivate are meaningful for them and their patients, and we're thrilled about that.
So the process of practicing that you were just describing, I've definitely heard of the standardized patient before. My wife is actually a physician, so I remember when she was in medical school, learning the basics of an exam, coming home and telling me about that process. I'm kind of interested to learn, though, for this type of practice, are you coming up with scenarios and the kind of curveball questions just on, kind of synthesizing or examining what might have happened, or are you kind of examining prior interactions, or kind of what is the developmental process?
So we train our actors to display certain behaviors, certain emotions. We set scenarios up for the clinician and actor to run through together, and we don't run the whole interview or whole encounter like might have happened in some of the medical school training that I've had in the past. We let it go to a certain specific moment where we let people practice the skill that they help identify. So in the process of this, we train the actors to exhibit certain emotions, certain communication acts, and we let the participants right before their moment of practice identify what might be some of their learning hopes for that next interaction. And we let it go until an opportunity shows itself for the person to practice that. And then we'll pause after it, let the person reflect on it. And if they want to rewind and do it again to try something else, we let them rewind and do it again. And it has a nature of drills and practice that allow people to try different things on for size. And we find that to be really rewarding for people.
It does sound like a very unique opportunity to, in a controlled environment, kind of determine or practice an approach that is going to be helpful in a situation where, not to say you can get it right or wrong per se, but it's where when you're then with an individual in a real life setting, you've kind of built the muscle memory, so that way it's you're going back to what we've been saying, more present, more in the moment, and more attuned to the particular individual that is going through the experience.
Absolutely. And when you'd asked that offer that there were kind of three things, and I've given you two so far. The third thing is that when you're moving from the basic skills of communication to, let's say, what might be expected in specialty palliative medicine teams, or maybe in any clinician who really values conversations and communication deeply, is what I find the next steps are to really help people cultivate an acute sense of situational awareness, both within themselves and outside of themselves. What's happening in a conversation, really what's going on, and to cultivate enough of these basic skills of varied types. In some ways, you have a toolbox full of different ways of handling different points in conversation, so that you really have communicative flexibility to help navigate a conversation in real time, rather than doing one thing you do well. So I would say that those steps of situational awareness and flexibility are really what take good to great.
So kind of thinking about what you just said there, which is, having the situational awareness and, kind of having an understanding of the different means of responding, as you examine how different people handle the interactions, is it that the approach is specific to each individual? And I guess for that question, I'm thinking of the physician perspective. I think obviously every single conversation is going to inherently be unique, but trying to learn whether there's a core set that's of responses or ways of responding that are teachable, and it's those are consistent, or is it really that the physician engaging in the conversation, it's always going to have kind of that personal overtone, and that you have to figure out what works for you?
I think we struggle that as a discipline. I mean, on one level, in order to train and structure conversations so that we can help, in some ways, change the face of healthcare so that these types of conversations are routine and expected, we have to, in some ways, standardize them so that we can begin to, let's say, document the conversation. For example, in order to organize these valuable skills into a type of conversation that might be useful for, let's say, my referring teams or other clinicians to read about our interaction, there may be an arc to a conversation that is about the person's values and preferences and identity and what suffering means to them in a way that will cultivate a little bit of a conversation map in some ways. And that can be really helpful when you're trying to engineer a system to communicate better, whether it's creating documentation templates or rewards and incentives or expectations, meaning that I'd like people to be able to look for a note in a medical record that helps understand who the person is. And wouldn't it be wonderful if that becomes just expected? The potential problem with that then, of course, is a little bit what you mentioned, is that if we just teach a really core set of skills and say this is the one way to do it, you'll get one way to do it. For some people, in some situations, it may work well. In others, it really may fall flat. So we, I think, have a productive tension between wanting people to have their personality and flexibility in different ways of communicating, while at the same point having some common language that we can help cultivate in healthcare for the seriously ill that can be of value.
In that tension that you just described, feels like it goes back to the traditional core way of describing medicine, which is that it's the art of medicine, and you really can't go have the pendulum swing fully in one direction or the other in terms of clinical science, the clinical science background or the full, personal empathy side. It's, there's always going to try to be a fine line balance, and it's going to be a work in progress because no one is ever going to be perfect at it, which I think is a tough aspect to come to grips with.
I think so. I think our colleagues in some of the environmental sciences and complexity science have really mastered some of these things that we struggle with. Meaning, I think of conversations ecologically, that there are going to be different behaviors, different structures to them, that you can measure those things and you can understand those things. And sometimes they may look like one type of bird, for example. And that conversation is not good or bad. It's just how well it functions in the context and what the patient's context is, what the clinical context is, what people's hopes for that conversation and motivations are. And what we really need to get to in a science of serious illness communication is really to flesh out what are the different types of species of conversations and what are the contexts within which they work well and where they don't work well. And that's really going to be cultivating, I think, a dynamic and informative approach to what it means to communicate well that we can scale up and standardize and incentivize in a system that desperately needs it.
No, and I think that's a very concise and perceptive consideration of where the challenges and likely and hopefully the successes will lie. But believe it or not, we're already out of time. I want to thank my guest, Dr. Robert Gramling, for a great conversation today.
Matt, thank you. Wonderful questions, and I really appreciate your interest, and I hope your listeners enjoy.
And thank you to everyone listening as well. I'll echo what you just said, Bob, and keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.